Israel in the UK, bringing and wanting to bring academia together from different places on earth to Israel. So we decided it would be a important and good idea to bring those three countries, Israel, the US, and the UK together, as we are all experience a similar crisis with the coronavirus and a lot of advanced research about it. And each and every country is in a different phase of the coronavirus, which we assume could be a great helpful information to each other to share knowledge. So before we start, I want to thank, first of all, to the panelists that are here with us today. I want to thank Professor Joshua Epstein from New York University and Professor Michael Onsel from Oxford University and Dr. Baruch Barzel from Bar Ilan University from Israel. And of course, I want to thank our only female here in the panel, which we are very proud. I want to present Dr. Michaela Martinez from Columbia University. Before I will present Michaela and bring her the stage to speak with you, I want to thank also you that you are joining us today. We have a lot of different guests, which is amazing, from different locations all over the world. So of course, be obvious that we have people from the US and people from Israel and people from the UK, but we have people also from Peru and Brazil and Mexico and India. And we're so happy because it's really, I think coronavirus bring a lot of negative things, but the one thing that is very easy and positive is the easy path to bring people together. So we're happy to be part of it. As well, I want to thank all of our friends in the UK and in Israel and in the US who are joining. We have here also a lot of professors and PhD students and NGO and journalists that joined us today. So be hoping that this will be helpful for all of us. I want to give the floor and the Zoom for Dr. Michaela Martinez. Dr. Martinez is an assistant professor of environmental health sciences at Columbia University in New York. She is an infectious disease ecologist who specializes in the transmission of acute infection disease. Her lab is researching the immunity transmission and racial inequalities in COVID-19. Thank you very much.
Thank you so much for having me. And so I would just like to take a minute to introduce our panelists. And so I'll go through one by one. Dr. Joshua Epstein is a professor of epidemiology and NYU School of Public Health. His research interest has been modeling complex social dynamics using mathematical and computational models. He was awarded the NIH Director's Pioneer Award in 2018, which is a very prestigious award, only given to very few people each year. He has studied Ebola, pandemic influenza, smallpox, Zika, urban disaster preparedness, and contagious violence. Dr. Baruch Barzel is a physicist and applied mathematician, director of the Complex Network Dynamics Lab at Bar Ilan University. Dr. Barzel's research focuses on the dynamic behavior of complex networks, uncovering universal principles that govern the dynamics of diverse systems, such as disease spreading, gene regulatory networks, protein interactions, and population dynamics. Dr. Mike Bonzel is a professor of mathematical biology in the Department of Zoology at the University of Oxford. Particular themes of research in his lab range from problems in mammalian developmental biology and stem cell dynamics, ecology and evolutionary biology, and the dynamics of infectious diseases and psychiatric disorders. I would like to note that all of our speakers today have very diverse backgrounds. So they are here to talk about their work on infectious diseases. But as you can see from their bios that I just shared, they have also applied their mathematical skills to other problems, such as natural disasters, psychiatric disorders, etc. So all three of them are very well-rounded mathematicians and biologists. And with that, I think we are going to start with Dr. Joshua Epstein is going to kick it off and share his presentation with us. And also, whoever is in charge of the monitoring, could you please turn off the chime for when people are coming into the waiting room, so that as the speakers are speaking, we don't continue to get that?
Yes, sure.
Thank you.
All right.
And so with that, I would like to pass it over to Dr. Epstein.
All right, let's see if I can share my screen. I seem to have lost contact with the group now. Zoom meeting. This is us. Let's see if I can share my screen.
We can hear you.
Okay, can you see that?
Yes, we can see that. Thank you.
All right. Okay, I'm going to go very fast because we're trying to squeeze in a lot, but this is about a modeling perspective on this. Can I kill that waiting room sign? I don't want to see that. All right, anyway, so this is the idea. Yes, my affiliations are these. I wanted to talk quickly as a first speaker about epidemiology in general, from playground to planet, in about 10 minutes, and start with some toy models that'll get us started. So here's a toy playground epidemic. Blue kids are healthy, red kids are sick. It's a little playground, a green patch, and we have one sick kid, and he's going to move around at random. When he bumps into a blue, he sneezes on him and gives him the disease. That turns the blue kid red, and after being red for a while, you die. You leave the playground. So you can see the thing starts spreading. Red kids are giving it to blue kids. They're turning red, and after being sick for a while, red kids leave the scene. You could think of them as dying or going to the infirmary or otherwise leaving. But in any event, they're gone from the circulation pattern. And what happens in this case, with no background immunity, no behavioral adaptation, no vaccine, no interventions of any kind, everybody gets the bug and they all die. All right? Now, obviously, we want to avoid that. Interventions are meant to avoid that and protect healthy, susceptible kids as much as possible. And the big tools for an epidemic like COVID-19 are vaccination in the long term and social distancing in the immediate term. So let's quickly run through those ideas. Vaccination. All right, so let's go back to the playground. We have 100 kids. Everybody got it and they all died. Imagine a perfect vaccine and that I vaccinate 60 kids right up front. So if I have a perfect vaccine, I vaccinate 60 kids survive, right? I would think that. I mean, if you walked up to me and said, "Excuse me, sir, I have a perfect vaccine. I'm going to vaccinate 60 out of 100. How many survive?" I'd say 60. But is that really what happens? Here's the same playground. We have our red initial guy. These blue children are susceptible, and we're going to vaccinate 60. These are the yellow individuals. If vaccination protected only the vaccinees, only the yellow kids, then at the end of the run, the yellow kids would be the only ones alive, right? Well, here's what really happens. There's spread, and I'll go forward quickly because we have little time. And what happens is, no, it's not only the yellow kids that survive. It's not only the vaccinees. The vaccinees confer secondary protection on the susceptible kids. And this is what's interesting about vaccine, and many of you will recognize this idea. This is the idea of herd immunity. I vaccinate 60, but more than 60 survive. So I don't have to immunize everybody to squash the epidemic. I just have to vaccinate enough so that it fizzles out. So what fraction of the population has to be vaccinated to induce herd immunity? Well, it turns out, as my colleagues will undoubtedly review, to a first approximation, I have to vaccinate, the fraction vaccinated is 1 minus, 1 being the total population, minus 1 over something. What in the world could that be? It's the famous R naught, right? We hear a lot about R naught. And if you vaccinate 1 minus 1 over R naught of the population, then under heroic assumptions about mixing and vaccine, blah, 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 you get herd immunity. So if R naught is 2, then you have to pre-vaccinate 1 minus 1 over R naught, but R naught is 2, so it's 1 minus 1/2. So you have to vaccinate half the population. Getting the vaccine, getting it fielded, developing it, and getting it out there is one challenge. But another one, I think this is a long-term part of the exit strategy, is getting people to take the vaccine once it's fielded. WHO ranks vaccine refusal among the top 10 threats to global health, and it's permitted the recurrence of measles and other preventable diseases, including polio, worldwide. Swine flu was a declared pandemic, but 50% of Americans declined the vaccine. So using our little formula and assuming a COVID-19 R naught of 2, this varies, of course, the same refusal of 50% would put us at the tipping point of a second wave. And I think talk about warp speed development really doesn't help. It feeds the idea of hasty development and may play into the hands of anti-vaccine groups. And even then, probably we don't have a vaccine until 2021. Before then, we have a different strategy. So part of the long-term exit strategy is develop the vaccine and get people to take it. Between now and then, we don't want another wave. And here, social distancing is the main instrument. China imposed this, but they did it too late. Too many cats were out of the bag, and things spread very quickly around the world these days. Here's my planetary scale model that was featured in Nature and published in a technical journal. We're going to start a pandemic in Thailand. Black kids are healthy, red kids are sick, blue have had it and died or recovered. It gets around the world in a huge hurry by international air and ground travel and the rest. Once it's in China, things spread heavily. This is an H1N1 simulation. And this is one of the larger agent-based models. It has 6.5 billion software individuals moving around this map. So you can study travel restrictions, all sorts of other things. But again, we're living in a highly connected world, and pandemic diseases can get around the planet in a big hurry. This is one of the reasons why early intervention is a huge deal. Epidemics are nonlinear threshold phenomena. They start out small, and in their initial phase, they explode exponentially. This is why early intervention is so crucial. Exponential curves with different growth rates separate very quickly. Here's exponential growth at growth rate 1, and here's exponential growth at growth rate 1.1. It's only 10% higher, but there's a huge vertical drop quite quickly, right? So this is what makes it entirely plausible that Jeff Shaman and others at Columbia, their estimate that a 3-month delay caused perhaps 36,000 lives. That's entirely plausible, given the exponential nature of the early epidemic. All right, so what we're seeing today is more than one epidemic. There's one contagion of the disease, but there's another contagion of fear of the disease, which affects our distancing behavior. And we have a model. One of the lines of work I'm interested in is coupled contagions of fear and disease. There are two contagions, one of disease, one of fear. You can get the fear by seeing someone sick, or seeing someone scared, or seeing someone sick and scared. If you're scared, you can lock yourself in the basement. That suppresses the disease, but because the disease is suppressed, the fear goes away, and people come out of the basement prematurely, and it generates a second wave. For those interested in the mathematics, here it is in all its gory detail. It's basically classical models, like my colleagues will review, one of them for disease proper, one of them for fear, and they're going on at once and interacting with one another to produce second waves. So here's the idea. The disease is red, it starts, it produces a big fear spike. This sends people into the basement, that suppresses the disease, but because there's not much disease, people come out of the basement and it sends them back into circulation. It pours susceptibles onto the infected members and you get a second wave. And this is just what we saw in 1918 in many US cities. And so, yes, 2 seconds and I'll be done. Okay, great. So this is what happened, and this is what we have to avoid through premature lifting of these measures. And it's what we're seeing in the United States. In many states of the US, there's haphazard reopening, and this can produce large second waves. And we really have to avoid that and get to the vaccine phase without a whole other round of closures and the rest. So to me, the two-pillared exit strategy is, one, we have to relax social distancing in phases, as I think my colleagues will elaborate. supported by broad testing for cases, PCR testing, contact tracing, antibody testing, to avoid second waves of epidemic between now and the fielding of the vaccine. Then we have to prepare people to take the vaccine when it's fielded, universally if possible, for disease eradication or for sufficient levels to produce herd immunity. So those are my thoughts at the moment, and I welcome responses now or later, and I turn the floor over to my colleagues. Thank you very much.
Wonderful. We still have another minute or so. Is it possible to take a question for the audience if anyone has a specific?
Sure, of course.
Let's see if there was anything that came up in the chat. I'm trying to check. Well,
just if you could unshare your screen so they could see you better.
Stop sharing, of course.
Okay,
sorry.
So
there you are. Good.
Here's a question from Milton Zingerman. Isn't it true that until there is a vaccine, international travel is a danger to Israel and you're stuck within a lockdown society?
I think until there's a vaccine, international travel is a danger to everyone. Yeah, I mean, we have to be very vigilant about that. And I'm not quite sure we have a perfectly, a very good answer at the moment. So yeah, I think transmission on airplanes is a complicated matter, and people being screened coming off airplanes, and the whole issue of asymptomatic spread, of course, is haunting all of this. I mean, even if you get on the airplane and test negative, if we had a rapid test, it doesn't mean you can't spread. The jury is really out on a lot of coronavirus and its behavior.
And I think we have one more quick question. Do you think that we locked down too late in the United Kingdom?
Probably. I mean, we certainly locked down too late in the United States.
Wonderful, thank you for that. And next we are going to have Dr. Barak Barzel. If you would like to share your screen, wonderful.
Hi, thank you very much, both for the introduction and for this beautiful talk. How do we mitigate COVID-19 without completely crippling the economy? So my lab at Bar-Ilan University is a network science lab. We usually deal with infrastructure networks, biological, neuronal networks, but of course, over the past couple of weeks, we've been very much focused on the spread of epidemics on social networks. And we came up with a strategy, alternating quarantine, which we believe can address the problem that I opened with, mitigating COVID-19 without fully crippling the economy. So what is alternating quarantine? Well, first of all, you take society and you partition it into two groups, cohort number one, the red group, and cohort number two, the blue group. And then you have these two groups alternate between going to work, social activity, and quarantining at home in weekly succession. So to make it simple, in week number one, the red group goes to work and the blue group isolates at home. And then in week number two, they switch and they continue this switching routine as long as the disease is still in prevalent numbers. Now, what's so good about this idea? Well, the first thing is that you save the economy. You have a continuous 50% economic activity at every given point in time. Restaurants, businesses, schools are all active, only at a 50% capacity with half of the population. Also, in terms of the individual experience, it's very stressful for the individual to sustain a very long, extended lockdown at home. But the individual experience in the alternating quarantine routine is that you only need to isolate for 1 week at a time. And then you can air out and resume your normal activity in the week after. So that's the alternating quarantine and the reason why it's so good for society and for the economy. But what does it do to the epidemic? Well, alternating quarantine is a good mitigation strategy for two reasons. And the first one has to do exactly with the R0 that was just introduced to us. You see, let's think about other alternatives to get a 50% economic activity. Well, one alternative, which is very natural, is to just isolate half the population. You have cohort one, the red group, constantly at home, and cohort two, the blue group, constantly going to work. What you do by that is that you reduce the interacting population by a factor of 2. Half people on the buses, half people that you interact with in the office, classes are half full. So roughly speaking, people have half the social interactions that they would usually have, and that cuts down R0 approximately by a factor of 2. I'm kind of stupefying things here, but let's keep in mind that this is a simple model here. The other option to have a 50% sustained economy is by having both groups alternate together. Everyone stays at home for 1 week, then everyone goes to work the next week. And this also cuts down the infection rate by a factor of 2 because you dilute the interacting time. People interact for only half the time because 1 week they isolate. But here's the point. Each one of those cuts R0 roughly by a factor of 2. The thing with alternating quarantine is that it benefits from the best of both worlds. And now I need to concentrate it for a little bit because there's a little mathematical magic trick here. You see, on the one hand, you partition population into 2 non-interacting cohorts. That means you dilute the interacting population. You cut down R0 by 2. And then on the other hand, you also, for each one of these cohorts, they work in weekly alternation, 1 week of work, 1 week of isolation. So they only interact for half the time. Here's another factor of 2. So what you get is that you reduce the infection rate by a factor of 4 while still sustaining the same level of activity. You still get continuous 50% economic activity. So it's the only strategy that allows you to sustain 50% economy, but 25% infection. And cutting down R0 by a factor of 4 is dramatic. Most of the current models will indicate that this in and of itself is enough to squash the disease. But there's more. You see, up until now, we talked about something very general. That was true for any epidemic, but there is something in the alternating quarantine that is specifically tailored for COVID-19. And to understand that, we asked ourselves in our lab, why is COVID-19 spreading so violently? I mean, people are very cautious. If I show symptoms, if I have a fever or I cough, nobody gets near me these days. So how come the disease continues to spread? Well, I think Professor Epstein mentioned it. And that is the fact that this virus has a very cruel weapon against us. So the disease cycle is very complicated, but I want you to focus just on one thing. And that is the fact that from the moment you get exposed to the virus until you start showing symptoms, it takes on average 5 days. And during this latency period, there's already a window where you're starting to infect others. We call these people the invisible spreaders. I might already be infected, and I'm spreading the virus. I'm infecting others, and they're being infected by me because we're not cautious around each other because I'm invisible. I have not shown yet symptoms. So the fact is that the invisible spreaders are the primary contribution to the spread of this virus. But how do we isolate those non-pre-symptomatic individuals? Well, you can't. They're invisible. So you can't really selectively isolate them. But alternating quarantine actually helps you out with that because, and this is another slide where I need your concentration for a second. Consider a person in group number 1, in the blue group. So in week number 1, that person, and they might actually get exposed to the virus. Now they're entering their most dangerous phase because they haven't yet developed symptoms, but they might already, in a couple of days, start spreading the virus. But here's the point. Within 5 days, they will enter isolation during week number 2. So the alternating quarantine isolates you exactly at the point of your peak infection. Now, during week number 2, when they're isolated at home, they will either develop symptoms and then they're isolated, they're no longer invisible and they know they need to stay at home. Or if they've already been at home for a week and haven't developed symptoms, then most likely, and I'm saying most likely, it's not certain, but most likely they're not infected and they can resume their work according to the alternating quarantine routine. So let's just summarize this up. What are the merits of this idea of alternating quarantine? First of all, it saves the economy, but it does that while reducing R0 by a factor of approximately 4, which is dramatic. And then it also naturally synchronizes with the COVID-19 disease cycle to selectively isolate people precisely at the point of their peak infection. So with all this, you would like to see some results. So we have more complicated models, but we use the basic model here, and there's a lot to unpack here. So let me do this gradually. You see, what you see here is the number of infections versus time. In orange, what you see is the unmitigated epidemic. What would happen if we do nothing? And it goes way off the screen, it hits the ceiling and goes back down. We don't want to go there. That's definitely bad. Then we have the two competing strategies where you isolate 50% of the population or you isolate them 50% of the time. That's turquoise and red over here. It suppresses the disease, but not enough. But where is the alternating quarantine? Well, we need to highlight it. It's all the way down here. You see in green, what you see here is what happens if you completely shut down everything. You set the infection rate to 0. That's a mathematical, theoretical possibility. There's no way to actually achieve that. But here's the point. It sets the absolute bounds for mitigation. You can't go better than that. Well, alternating quarantine is not as good as that, but it's in the same ballpark. It's not so bad. It actually suppresses the disease very effectively and allows you to resume normalcy within a reasonable time frame. So we thought that this idea should not remain a mathematical idea, but we actually put together a team with all the relevant experts to talk about how to implement this idea. Now, there are many details here, but I just want to talk about one of them. And that is, how do we garner cooperation? So when we think about enforcement of a strategy, because half of the people are out, half of the people are in, it's kind of difficult to enforce that. When we think about enforcement, what we have is in our mind is policemen chasing civilians. But the truth is that it's not about enforcing things. It's about garnering natural motivation for cooperation. You need to create motivation and a framework where people can naturally cooperate. Well, what are the inhibitors for cooperation? People want childcare, send their kids to school. People want to go to work. Well, the alternating quarantine routine is based on the fact that it's a national strategy. You can't send your child to school out of cycle. You can't go to work if it's not your shift. You're not going to be admitted to your workplace. Then people might want to go to public centers like shopping malls. But here's the point. You're only isolating for 1 week at a time. And if you're only isolating for 1 week at a time, you can get supplies in advance. You don't have to go and do any errands that week. And if there's something unexpected, like the fridge broke down and all the milk got spoiled, fine. So we're going to have every local authority have a task force that helps you solve these problems without violating your quarantine week. The idea is to create a framework that garners cooperation. Lastly, we can establish a mobile app. Now, I know people do not like apps issued by the government, but this app doesn't spy on you. It doesn't read your emails. It just says one thing. Are you in the red group or in the blue group? You want to enter a shopping mall? You'll only be granted entry if you show that you're in the correct week. If this is the red week and you're in the blue group, you're going to be denied entry. So there's just no way to cheat this. And there's no motivation to cheat this because you can't actually go out during your lockdown week. What about going outdoors to stroll with the dog or for exercise or walk with the kids? Well, you could enforce that with the app, but the truth is, just let it go. This risk infection of outdoor activity is so weak that we can just allow people to air out during their quarantine week. I want to finish this just with one point. You see, when we were starting to talk about the implementation here, and we understood what are the details of the garnering cooperation, we understood that there's a very big difference between alternating quarantine and full quarantine, because you cannot have a 100% full lockdown for an extended period of time. People have to get supplies. So supply chains and supermarkets have to be open. Medical staff, they need to eat too. They need to take taxi cabs to their work and home. So there's no such thing as a 100% quarantine, but alternating quarantine, where you only have to isolate for 1 week, is actually doable. So what happens is that most countries that have established a population-wide quarantine, at the most, even at the most stringent enforcement, we're able to achieve a 70 to 80% level reduction. And the point is that alternating quarantine, this blue curve here, achieves roughly the same level of mitigation as a 75 to 80% population-wide quarantine, which means that you can achieve the same thing, but without the devastating socioeconomic price tag. Now, we all understand, and we just saw that we're going to have future outbreaks. So even if you're in Israel, and right now numbers are very low, it's clear that every citizen should expect their country to have a plan which is a little bit more resolved than just saying everyone stays at home if wave number 2 erupts. I think this plan should be alternating quarantine. And I think that now is the time to speak about the details of how to acquire national level alternating quarantine capabilities. Thank you very much. I'd like to also thank all my lab who's been working nights for running simulations for all sorts of governments and agencies that were interested in our ideas. So we've been very, very busy with this. We've been running simulations and talking to all sorts of governments. And we are always open to more comments, more ideas, and more questions. Thank you so much.
Thank you, Dr. Barzal. I would like to just take one question with the audience since we're a little short on time, but we'll get back to questions. I'm paraphrasing, but one person asked, would this alternating quarantine require an unrealistic level of self-discipline?
So the answer is absolutely, I think the answer is absolutely no. I mean, the first thing is to get people motivated to understand why the strategy works and why their cooperation is needed. But we all know that that's not enough. At the other extreme, you have policemen chasing civilians. Show me your app. Show me that you're allowed to be outside. that's also unscalable and very bad for a democratic society. In the middle is you create frameworks that naturally guide people towards cooperation. If businesses are liable to work in shifts, and we need to give them time to get arranged for that. So we need to start talking about this now. And if schools are liable to partition classrooms into shifts, there is really no way to cheat. So it's not based on individual motivation. It's based on creating a framework for cooperation. I like to call this, just one sentence, it's the dietary equivalent of not having any chocolate in the fridge. You just cannot cheat. It's not about having motivation not to eat the chocolate. It's not about having punishment. If I eat the chocolate, someone is going to punish me. It's about creating the framework where there's no temptation to cheat.
Great, thank you so much. And we'll have time for more questions at the end. And lastly, I would like to introduce Dr. Mike Bonsall. And we'd like to pull up his presentation. Wonderful.
So I hope everybody can see my screen. Yep, good. All right, so thank you very much for inviting me. It's a great pleasure to be here. Great set of talks I've just heard. So hopefully I can fill in a little bit of details about some of the modeling work that we've been doing looking at exit from lockdown strategies based here in the UK. As has been said, I'm based in Oxford, and I'll get to sort of talk about some of the stuff that we've been doing. So for the last couple of years, my group have had a broad interest in sort of existential risk and biosecurity and sort of pandemic preparedness. And from that, we've sort of like focused what the WHO call on disease X, essentially. So really thinking about a novel emerging pathogen and how we should develop countermeasures to sort of like deal with that. So obviously the COVID situation has presented us with a really interesting scenario to be able to test out some of the ideas that we've been thinking about. So disease X is we were thinking about non-pharmaceutical interventions, so public health interventions like the ones we've just heard, to do with interventions that don't necessarily involve drugs or vaccines as part of a control strategy to focus on these novel pandemics. And one of the ways that we can do that is to really think about two things. One is about quarantine, and one is about developing diagnostic tests. And as we heard, the standard way for thinking about disease modeling is to build these SCIR type models. So having a susceptible group of individuals, an exposed group, and an infected group, and then a recovered group. And we can really think about how we deal with that, how we deal with understanding these sort of like this pandemic, the risk of pandemics through quarantining. And if we sort of have a diagnostic test and an early diagnostic test to be able to identify individuals that are infectious, then we can put them into a quarantine class and look at the implications that might have for disease spread. And one of the things that we do, so just to concentrate on these graphs, just taking this, this is the proportion of infected individuals against time. So just concentrate on the blue line and the orange line. So this is where there's no intervention, and this is where there is an intervention, where we've got a platform diagnostic, a diagnostic test that tells us that people are infected, and we might want to think about quarantining those individuals to prevent further infections. Two things that emerge from this: early diagnostics will reduce the size of the infection, but also they spread out the length of that infection over a longer period of time. So those are two things that are really critically important in public health planning. One is that we change the size of that epidemic, and we also influence the spread of the breadth of time over which that disease might persist. And what's crucial in all of this is actually the sensitivity of these model predictions to particular parameters. And one of the things, and we've just heard from both the previous speakers, that understanding asymptomatic individuals, so those individuals that are exposed but not necessarily know they're infected, but actually are infectious to other individuals, can really affect the transmission of these novel pathogens. So what that led us to, that piece of work that we've done, has led us to, is we're thinking about how do we sort of blend that thinking about diagnostics and platform and quarantine into developing an exit model from lockdown, essentially. So we have, again, the SCIR type framework. So we've got a bunch of individuals who are released from quarantine, individuals who are in quarantine, and the main difference between individuals, those that are in quarantine and those out of quarantine, is a reduction in the potential for the disease to transmit. And what we then ask is, what we're really asking is, what is the optimal release strategy from quarantine? There's a very well-worked set of mathematics around optimal control and thinking about, given a set of constraints, what is the best solution? What's the good enough solution that you can get to from simulation or analysis of these mathematics? So our approach was to say, well, we set the system up. We have individuals in quarantine, individuals who can be released from quarantine. Given sets of scenario, what is the optimal way that we would allow people to emerge from quarantine, given a set of assumptions about the transmission? And as already been highlighted, we have to consider that there are asymptomatic individuals, there may be super spreaders, and there may be individuals who are more susceptible to the disease than others. And we have to factor that into the way in which we build these infection models. So we could work through the maths of this, and we did, and we got lots of headaches, and it was very frustrating, and we wanted to throw the computers out the window because they weren't giving us any sensible results from our paper and pen exercises. So actually what we reverted to with this particular approach was a numerical approach to optimization, our optimal control problem. We set a constraint, and our constraint was that the infections, the number of infections could not break a ceiling. It was fixed in terms of, in the case that we've been modeling, the number of beds in ICU clinics in UK hospitals. So that was our upper constraint. We did not want to collapse the health service by having more than that many people infected at any one point in time. And then we considered two strategies, a gradual release from lockdown and an on-off release lockdown, a little bit like the alternating quarantine model you've just heard about. And we wanted to ask which one of those two scenarios would be best placed to minimize the number of infections, minimize the risk of second infections, and maximize the number of people that you could get out of quarantine, out of this lockdown situation at any one time. So we have these, so there's a detailed maths. I'm more than happy to bore people about the maths if they want to, but these are our goals, was to release, the gradual release, to release as many individuals as possible, as early as possible, without breaking that infection carrying capacity, the number of beds in the hospitals, or on-off strategy, so that's alternating quarantine strategy, the longest possible duration we could leave people out of quarantine, again, and do that as soon as possible without breaking, again, the infection carrying capacity. So as a set of parameters, all of these models need careful parameterization. And obviously in this situation, we're in a sort of like an emerging epidemic, and there's lots of uncertainty about lots of the parameters in the model. So there's things to do with like the transmission rate, the background death rate, the recovery rate, the threshold of infections. All of these need careful parameterization. And obviously the results that we present are based on a chosen set of values. But again, sensitivity analysis, asking how robust are our results if we vary those parameters, is critically important. And we've worked through lots of that analysis. So here's just an example. This is an example for the release strategy, for the gradual release strategy. We've got quarantine, those in the lockdown population and those in the non-lockdown population. So individuals here in quarantine, they're released at this point in here. You see them emerge into the non-quarantine population, and a few days later, you see a spike in the infection. And then basically, so we reach half of the population here, and then the rest of them are all released at day 200. We see another spike of individuals re-entering the workforce, if you like, and then another spike in infection. And again, what we're trying to do, I emphasize, we're trying to keep that re-emergence of the re-spiking of infection as low as possible to not break this infection carrying capacity. Here's an example of the on-off strategy. So everybody's released here out of quarantine. We see a spike in the number of people re-entering the workforce and a spike in the infections, and then it fades out as people enter a recovered class, essentially. So those are just examples. Here's a couple of, here's the sort of like exit strategies for the optimal exit strategies for the gradual release. I know this is a crazy slide, but just bear with me. We've got three different parameters that we're looking at: the threshold, that carrying capacity, the transmission rate, and the reduction in transmission if you're in quarantine. So if we just follow this gold line here, this is for an infection threshold where we say there are 8 million beds essentially, and we would release individuals at say a day 150, so half of the individuals are released, and then we release the rest of those individuals at day 200. This is the infection dynamics. This is what would happen. We'd end up with a very large sort of spike in the infections and then a couple of recurrent peaks essentially. If we take the UK model, there's about 4 million beds, which is this dotted line here, then we would release individuals following this sort of this teal line here, where we release individuals around about a day 100 and another set of individuals maybe 100 days later to minimize the number of infections. We can look to see how transmission or reduction in infection, the transmission affect those sorts of optimal decisions. And we get similar sorts of results. We have to release individuals in waves, this gradual release in waves to prevent this respike of infections and hitting this infection carrying capacity. So for the on-off strategy, so very similar to what we just talked about, again, just following this gold line, we would release individuals, all individuals come out, and then we get a spike in infections. We hit that carrying capacity. We have to force everybody back into quarantine. We force everybody then comes back out again. And we see these recurrent cycles of in and out of lockdown. And it's never optimal to leave an entire population out of quarantine for very long, essentially. So the optimal solution here would be to lift quarantine for 1 or 2 weeks, very similar to what we were just hearing about the alternating quarantine model, and then to put people back into lockdown. But overall, contrasting these two approaches, it turns out that if our goal is to prevent collapse of health systems and to plan our public health strategies accordingly, our best strategy would be to release individuals gradually over a number of waves. This on-off strategy gives too much spikiness to the recurrent infection dynamics, and it becomes very difficult to control the disease and the recurrent disease over the longer term. So just a couple of things just to finish up. As I said, the sort of diagnostic test stuff is a really insidious problem with this particular coronavirus, and we really need to get a greater handle on that asymptomatic levels of infection for parameterization of our models, understanding the risk that individuals who are asymptomatic, carrying the disease but not overtly infectious to individuals, pose as a public health risk. And we have an ongoing study here in the UK and in the community, and I mean around Oxford, of being able to test people. We've got about 3,000 people in a designed experimental protocol to actually look at the efficacy of diagnostic testing, to look at the prevalence of this virus in the community. And the work I've just presented very fortuitously has just come out today in Frontiers in Public Health. So if you're interested in reading more, it's on an open access journal, and you can download it, and it's there to read. And I'd just like to thank the people in the group, so Cassidy and Simina, who are leading the diagnostic test stuff, and Tom, Chris, Tom, and Desi, who have been doing, as Marshall said, the late night simulation work on all of this, and a bunch of people who've supported us. So thank you very much for your time.
Thank you for that. And I'll have a couple questions from the audience. So one person asked, how much would alternating quarantine help if it were implemented by, let's say, universities, for example, and not at the national level?
So that's a really good question. So the great thing about this model is it's completely scalable. We placed it at the whole UK scale. But if we have infection dynamics at a local, citywide scale, or even smaller than that, we knew the capacity of what we were constraining against. So that might be, number of beds in a university or number of beds in a hospital, then we can apply it at that sort of scale. So understanding that the application, that this is completely scalable from very small scale to a very large scale problem would be something that we could look at. We haven't done that, but it will be super easy to do that. But again, all of this stuff depends on knowing what your constraint is. What stops, what are you trying to do? What are you trying to control against? And as I said, our control against was not to collapse health service. You might want to say, actually, what you don't want to do is to, max out the number of university lecture seats that you take, or whatever it might be, essentially. So as long as you have that, this is completely adaptable to that sort of question.
Wonderful. And we have about 15 minutes left. So if audience members would like to add your questions in the chat, I am monitoring them. And I have a question for all three of you to address, which is going over the differences between a lockdown and a quarantine, and that there's some spectrum here in terms of people being able to go out. Walks were mentioned, grocery shopping was mentioned. So if the three of you can talk a little bit about that and how this factors into how you've been thinking about your modeling.
Yeah, it's a good question.
So in English, right?
Really
is there
about
a lockdown and a quarantine?
Yeah.
Maybe I'll try to take a jab at that one. I'm not. I don't know in terms of English, there's a difference. In terms of reality, I think this kind of resonates with a lot of other questions about social conformity and how much people cooperate and where people cut corners. So let me say two things about this. One thing is that we already mentioned is that you don't want to get social conformity by coercion. You want to get it by creating a framework for cooperation. Every model should take that into account. So I didn't go into details because I had only 10 minutes, but in our model, for instance, we assume that there is a certain level of social defection, people who remain active despite their need to be in quarantine. And part of the thing that you need to check is always the robustness of every method against the absence of social cooperation. What we found is that, for instance, the alternating quarantine routine is robust with up to 20 or 25% of defection levels. When I'm talking about defection levels here, I mean in our model, people who are flat out violating the rules. In reality, people don't do that. People cut corners. People don't completely violate the rules usually. But I think it's an important aspect of every strategy. You need to take into account not everything is fully under your control.
Did anybody else want to add to that?
No, I agree. I think that's really important, and that
Sounds right.
Is to say understanding the fact that you don't have conformity is pretty important, and what it does is it affects the degree to which you have. So the difference between quarantine and lockdown is how severe that is in terms of, just very theoretically, the difference between the transmission rate being at some level and it being at zero. So if it's at zero, your quarantine's working perfectly well, and you've had full compliance. And you've got to allow that. You've got, as was just said, you've got to allow that sort of flexibility. You've got to allow that potential for defection, essentially. And we in the framework that we just had, we reduced transmission by a factor. So it isn't complete quarantine. It's as Michaela said, it's sort of like a lockdown where there is still some disease spread within that, and you can capture that in a very generic sort of way.
Well, and if you're reducing R naught by a factor of 4, you can afford some imperfection.
Precisely. That's precisely the point. So we kind of assume worst case scenarios, but the truth is that even in your active week, you're probably going to still be, keeping social distancing. That's not the time to hug people. I mean, we need to change the idea to save the economy, not to go back to our old habits. So until there's a vaccine, we still need to keep the regular prophylactic activities. Now, in the result I've shown you, for instance, we didn't assume that. We assumed the worst case scenario. When you're active completely, just like you were before. In reality, of course, I mean, we need to take other measures that go together. Alternating quarantine or any other one of the strategies mentioned is a complementary strategy to any prophylactic behavior that we need to enforce.
I don't know what kind of meeting is this, but you can't hear any of you.
I'm sorry, but can the host please mute whoever that's not a panelist who's speaking? And also we have another question that I'm actually going to paraphrase a bit. So somebody wanted to know about ways that we can try to maximize vaccine uptake when we have a vaccine by incentivizing people that there's a social value to taking the vaccine.
Well, I mean, first of all, there are several issues. I mean, historically there have been, in the example of smallpox, for example, I mean, part of it is you have to convince people that the disease is a serious threat. If people don't think there's a threat, then there's several fears. There's fear of the disease, there's fear of the vaccine. And if people are not afraid of the disease, then the vaccine fear dominates and they don't take the thing and the disease comes back. So But part of it is to tell people you're taking the vaccine to protect yourself, but you're also taking it to protect others. You're trying to induce herd immunity. So there's a communitarian aspect to taking vaccine. You're protecting others and trying to induce herd immunity for everyone. It's not purely protecting yourself. So I think it needs to be communicated that A, the disease is very serious. Even if the prevalence is low, the whole point is you're trying to keep it low by taking vaccine and suppressing the thing and preventing resurgence. You're protecting yourself and you're protecting others. And of course, you need to convince people that it's safe and effective. And I'm worrying that the language of warp speed and the rest of it may play into the hands of groups that are trying to stimulate fear of the thing. So there's a lot of diplomacy we need to mount long in advance of the vaccine to make sure people take it when it becomes available.
And I have one more question that I think is really important to address. So somebody asked, can you explain why the graphs that have been shown today, the simulations, don't look like the actual case data of infections that you see reported? So I think it would be great to talk about the simulation.
Can I take that question, and can I share my screen again just very quickly with everybody, just to show a picture? This is hope you can see my screen. So this is the number of cases against time from London, through the sort of epidemic. So now our cases have all gone. So the red dots on this picture are the actual case reports from London through the last couple of months, essentially. And then the black lines are simulations of that we fitted one of those models, one of our models, to that data. And you can clearly see there are differences in this. Basically, we don't have those nice smooth curves that we see with our theoretical models, and that's because of case reporting. That you can see that every few days there's a drop in this. There's a drop in this graph, and that's our weekends, where we were pretty rubbish at sort of like recording infections at the weekend. So and there's lots of underreporting. The fact is that there's lots of noise in this data, the data that we collect, and the real challenge is being able to link our theoretical models to this sort of data. And it's really at the coalface of trying to map on what our theoretical models are telling us about lockdown, together with this sort of the data that comes in, essentially. So it's really to do with the way in which cases are reported, the speed of which they're reported, the testing that's done, the efficacy of that test, understanding that there is a set of people that may not be presenting in clinic for tests, knowing all of that asymptomatic. So there's lots of whole hidden stuff, lots of hidden variables in that we just need to unravel on. And the better we get at testing people, the more robust we can get at sort of fitting models to this sort of data. But it's a really good question and really crucial to our public health planning.
Absolutely, thank you so much. And another question was regarding vulnerable populations. So if countries were to move to a strategy of alternating lockdown, what about individuals over 65 or individuals with pre-existing conditions who may be more vulnerable to severe illness?
Perfect, thank you so much. So I will reiterate, I think it's important to understand. When we test alternating quarantine in our simulations, we use the worst case scenario, as if this is the only strategy you are implementing. Of course, when I advise to countries, I never advise them to do that. Alternating quarantine is a force multiplier. You want to selectively isolate the vulnerable populations? Of course you should. That's our duty, right? You should do that. And that will save a certain amount of people. Do that together with alternating quarantine, you'll save much more. You want to have people wear masks? Go ahead, do that. With alternating quarantine, you can do much more. I'll give you just one example. When we were talking with the National Security Council in Israel, they said, you know what? We were thinking of a gradual release, releasing 30% of the people first and 50% and so on. And we were looking exactly at what Professor Bonsall was looking at. Are we going to go beyond the cap of the capacity of the national healthcare system? It turns out that if you just release 30% of the people, it's not enough. You would go beyond the capacity. But then what we told the National Security Council, do that together with alternating quarantine. You can release 60% of the people instead of 30%. and gain a much more significant mitigation advantage. If you lost me on the numbers, the basic idea is this. Choose your strategy, which is based on isolating vulnerable populations, prophylactic measures, washing your hands, getting hooked on alcohol gel, all the things that we're doing. Reinforce that strategy with alternating quarantine, and A, you can mitigate the disease better. B, you can kind of suffer a higher level of lack of compliance or a higher level of uncertainty in the disease parameters. So it's a force multiplier to whatever strategy it is you want to decide on.
Great, thank you so much. And we'll take one last question. And that is, what about individuals living in the same household? In any of these alternating scenarios, whether it be the alternating Dr. Bonzo spoke of or Barzo, would individuals in the same household have to share their alternation weeks with each other so that someone's not out one week and bringing the infection home and then someone's out the next week and bringing the
Yes, precisely. Whoever asked that question got it right. The way to partition population is based on households. Me, my wife, and my kids are all in the same cohort. Otherwise, you start getting cross-infection. And there's a very easy way to do that. You partition people based on addresses. Everyone knows their address, so everyone knows exactly what group they're in, and everyone living in the same building will be shared in the same cohort. Then there's fine-tuning to do, because I need to call my boss and tell her, listen, I was assigned to the blue group, is that okay? She might tell me, no, I really need you in the red group. So we can be very flexible. Everyone who needs to swap, as long as they swap the entire household, you can swap. Why can I be so flexible? Well, first of all, because I want to make this as easy as possible for the people. And second of all, because you don't have to have an exact 50-50 partition. If there's going to be 55% in one group and 45%, it's perfectly fine. So the idea is to first of all partition based on addresses, and then every special request, if the business wants me at that week or that week, whatever, every special request can be granted as long as you have a reasonable partition. You don't have to keep it exactly 50-50. That's part of the strength of the method. It's very flexible.
Wonderful, thank you. And I think I will ask one more question and direct it to Dr. Epstein, because he shared some simulations from an agent-based model. And the question is, why are SIR models the only models used even now?
Well, I mean, I think that's they're not the only models. I mean, they're the predominant formalism is the SIR formalism, but I think a lot of us are very interested in doing models on networks, models with behavioral adaptation, all sorts of variations on that theme. And it's very important to do variations on the theme because the undiluted SIR perfectly mixed model runs very hot, and it doesn't respect the heterogeneity in populations or, again, these very, very complicated mixing patterns and so forth. So it's really like the ideal gas of epidemiology. It's where everyone starts and it conditions our intuitions and it made huge, important insights. But I think the field is moving far beyond that, I'm happy to say, and my colleagues are excellent representatives of that evolution. So good question.
Wonderful. And
we're all beyond the SIR. We use much more complicated models in reality.
Yes. And since we're a couple minutes over time now, I just wanted to give each speaker, each panelist, a minute to address the audience. Were there any last things that you wanted to say that you thought were important that you hadn't been able to say to this point?
The only point I rushed past it, but it's worth saying, and it comes out in Michael's graphs, is that, you know, there's a lot of people in the United States felt or do feel that, you know, once you're after the peak, you're out of the woods. But if you look at Michael's graphs and all the graphs, the peak is about halfway into the epidemic. So there's a lot of epidemic in front of you, even if you're at the peak. And maintaining vigilance through the end of the thing is extremely important. And we just can't become complacent because we're not seeing disease. This is what brought second waves back and can do so again.
Maybe my final comment will be this. I mean, I see a lot of the questions are about the practical implementation. Of course, if you want a strategy that's a little bit more resolved than just everyone stay at home, it requires some level of risk and some level of a much more resolved implementation. So any strategy that's more clever than the one we've been using until now requires a lot of effort. And there are many details in the alternating quarantine or any other of those strategies on how to do that, how to enforce it, how to create motivation. What about businesses with one person or businesses that cannot work in shifts or can be let exemptions? There are so many details here. And we've been discussing with many countries and we've been exposed to the kind of questions they're asking. And some of them are very, very detailed. So the answer is, yes, we should think about this. I don't know how to solve all of those details, but the answer is that since a second wave is imminent and it's probably coming, this is the right time to start thinking about these details. Should the app be just more than red or blue? Should we exempt certain crucial businesses? Should we selectively isolate people who have an elderly person in their household? All of these details are beyond what mathematical modeling can give and require the engagement of policymakers, of economists, and of business people. We've also been talking with a lot of professionals in the business sector who've told us what are their challenges with this idea. All I'm saying is that if we need to make all these details and if we need to get into a detailed plan, now is the time to do it, because in a month or two, when the second wave erupts, we should already have an implementable strategy.
My closing remark would be for our decision makers to be able and comfortable with embracing uncertainty. So we won't know everything, we won't get it all right, but actually we've got a good set of approaches to be able to do that, but there'll be still things that are uncertain on going ahead. And being able to develop these sorts of frameworks, all of the sorts of frameworks that we've held, provide us with a weight of evidence and being able to provide sound advice based on the science.
Thank you so much. And I would just like to say that the panelists today were really a fine example of scientists really stepping up to the plate in a time of great need and really putting all of their skills towards a big problem. And I really appreciate that. And I thank you because I know that this has been a time of quite extreme stress that is put on mathematical modelers. And so appreciate that. And would the host like to say anything in closing? I know lots of people are signing off. Have a wonderful day, everyone who's signing off.
Thank you all.
Yes, I will just say a couple of last words to thank all of our panelists, to thank you, Michaela, as our moderator, to thank, of course, our partners at the consulate in New York. I would say one thing that I believe that when we were thinking about the topic, it is always a question whether during this time, is it still relevant to speak about it? And what is it left to say? There are so many research that is being done. And I think this is just a perfect example of how 3 different approaches, 3 different states, could have a conversation, hopefully also learning from each other. And from our point of view, and I know that I'm also talking on behalf of the consulate in New York, we're also here as the institution to promote this type of cooperation. Please don't hesitate to write to us with any type of questions that you might have. We might be of use, we might not, but we definitely always want to be of use in this regard. So thank you to everyone.
Thank you very much.
Thank you. Pleasure.
Thank you very much.
Thank you. Have a good day and be safe.
Okay.
Thank
Okay.
you. Thank you. Good evening. Good morning.
And lastly, if anyone wants to Google the panelists, I'm sure you'll find lots of information on their websites. Okay. Bye.
Bye-bye.
Bye-bye, all.
Bye.